Hello, my name is Ealaf Shemmeri, and I'm a thoracic fellow coming to you from Swedish in Seattle. Okay. Thank you for the opportunity to present our work on achalasia. Dr. Louie discloses educational grants from Boston Scientific, Irby, and Olympus. Achalasia is a neurodegenerative disorder of the esophagus characterized by a loss of peristalsis and failure of the lower esophageal sphincter to relax. Treatment is palliative. The goal is to disrupt the LES, thereby allowing easier passage of food into the stomach. The Eckardt Score, here on the right, is the most commonly used primary outcome measure for myotomy. It is a severity score of 4 symptoms reported by the patient with a score greater than 3 defined as a failure. It is used to ascertain if further interventions are needed. However, it does not address the other changes that you've been hearing about so far experienced after myotomy, namely swallowing quality and the onset of reflux disease. Thus, there is a need for a more comprehensive assessment of quality after achalasia treatment. Our aim is to devise a report card that provides a comprehensive and informative assessment documenting the scope of outcomes after surgical myotomy for achalasia. We performed a retrospective chart review from 2005 to 2017. The study population included all patients who underwent a surgical myotomy for primary achalasia. We excluded those who had prior myotomy, previous foregut surgery, and pseudoachalasia. We reviewed all variables recorded pre- and post-operatively from the most recent encounter. We chose 3 components to group our outcomes. For patient-reported outcomes, we included the Eckardt Score, the DCAC dysphagia score, and the GERD health-related quality of life score. For objective testing, we looked at the pH score, time barium esophagram, IRP normalization on manometry, and endoscopic evaluation for reflux esophagitis. We recorded all reinterventions and recorded the most invasive one for each patient. Combining all 8 components gives you this report card format to clearly list the success in each domain. For patient-reported outcomes, we included the Eckardt Score of 3 or less as normal, the DCAC dysphagia score with 40 or higher showing good swallowing quality, and the GERD HRQL score with a score of 10 or less indicating minimal to no reflux. For objective testing, the IRP normalization to less than 15 on manometry was normal. Normal time barium esophagram was clearance at 5 minutes. No esophagitis on endoscopy, and a normal pH score of less than 14.72. For the reintervention domain, no reinterventions were recorded as a success. We had 185 patients with primary achalasia. The median age was 53 years. They were mostly female. The BMI was 25.7. The most common preoperative intervention was botulinum toxin injection, and the most common achalasia was type 2. We used POEM approach in 71 patients and Heller myotomy in 114 patients. 2 of those had just a myotomy, 20 had a toupee, and 92 had a door fundoplication. The median myotomy length was 4 centimeters proximal and 2 centimeters distal. Major complications included 4 patients with leak after a POEM and 6 patients requiring reoperation for dysphagia. These included 2 redo Heller door patients, 1 Heller door that was converted to a Heller toupee, 2 POEM that were converted to a Heller door, and 1 POEM was taken back for revision of the POEM. Patient-reported outcomes, when they were reviewed, we can see that the Eckardt Score is nearly normal in our patient cohort after myotomy. However, this is a stark contrast to their swallowing quality and the presence of their GERD being reported. As you can see, 45% and 72%. Objective measures show IRP normalized in 80% of cases. 5-minute clearance was achieved in 61%. Normal esophageal mucosa was recorded 71% of cases, but pH testing was only normal 50% of the time. Finally, success of not needing reinterventions is 79%. We had 19 patients who required small caliber dilation. 3 patients needed pneumatic balloon dilation. 2 patients had Botox injections. We had 2 redo myotomies. One was a Heller door that went on to get a POEM, and one was a POEM that had Heller door. We had 2 patients that required anti-reflux surgery. One was a POEM that had a toupee fundoplication, and one was a Heller door that required a toupee. Finally, we had 1 patient who underwent a POEM, developed severe reflux, had a toupee fundoplication, and then developed reflux plus persistent dysphagia and required a vagal-sparing transhiatal esophagectomy for that reason. So now, with all components appearing together, you can see how when you only focus on a singular outcome, you can miss the whole story that occurs after myotomy. Providing a comprehensive tool gives you the ability to identify areas of improvement in your achalasia practice. Its simplicity allows it to be applied in various settings. At the academic level, it provides a standardized research tool. This allows evaluation of technologies for post-myotomy analysis. At the health system level, it can be used to compare hospital achalasia outcomes and drive quality improvement processes. It can also be used at the group practice level to tailor operative technique for better results. For example, if you want to evaluate your myotomy technique, here's our database showing the report card for Heller myotomy and our POEM patients. You can see how the Eckardt Score again shows almost complete success with similar normalization of IRP and clearance of barium. However, swallowing quality seems to be better with POEM. Reflex esophagitis from the collection of the questionnaires and the pH testing, however, favored the Heller myotomy technique. The strengths of this report card are that it shows a comprehensive display utilizing readily available outcome measures that combine patient-reported outcomes and objective testing. The limitations are that we use direct retrospective review, when ideally it should be a prospective study. It would be also more robust if we had more patients show up for all required outcomes measures after their myotomy. In conclusion, the use of the Eckardt Score to assess outcomes after achalasia surgery shows outstanding results. Using patient-reported symptoms, objective measures, and rates of reintervention organized into a report card provides a more comprehensive and informative view. Thank you, and I'll take any questions.